So welcome to colleagues joining the joint UNFPA ESC webinar. My name is Kubba, and we have Professor Jane Hirst with us. Welcome you all. So good morning, good afternoon, good evening, wherever you are. Our webinars are attended by a global audience, but they are part of a collaboration between the ESC and the UNFPA, the United Nations Population Fund, and the collaboration involves a number of items, but we've been running regular webinars really addressing the need of the Eastern Europe and Central Asian countries of UNFPA. Our webinar today is about climate change, the impact on women's health, and we have two speakers. So Professor Hirst will start on the women's health in a changing climate, and then I will follow looking at sustainable services and resilient healthcare. You will see in the program and the flyer that you may have had that there were questions after each presentation. We've decided, because the topics are interlinked, that we will do our two presentations and we will then have questions for 20 minutes, and then we'll have the closing remarks. Can I have the next slide, please? The ESC office are managing the slides. The European Society of Contraception is a leading professional society working collaboratively in Europe and beyond. We champion evidence-based education and research in sexual and reproductive health and rights, and this includes facilitating people's informed decisions in choosing and using contraception. Next slide. Membership is actually very, very good value for money. So it is 170 euros for a year, but if you join for 2 years, you get a discount. So it's 130 euros for 2 years. It allows you free access to the webinars, because some of the webinars we may charge for. This is a free webinar because it's very generously supported by UNFPA. We have a regular newsletter. We have a journal. You have a reduced registration rate for our conferences and the Congress, and the journal and the database. The international or national European organization with similar related aims or institutions may also apply for affiliation. A minimum of 10 members are required to be affiliated, and if you are affiliated, then you again get a discount for all your members. So for instance, if my colleagues in the UK, we have a society, we affiliate, then we will all be able to get a discount when we register for conferences. The practicalities of this meeting is, if you have questions, it is through the Q&A. Click on the Q&A button. We will not be able to answer questions if you put them in the chat. You can upvote each other's questions, so you click on the thumbs up sign, and we will address the questions. If we do not have time to answer all the questions, we are a bit different in the sense that we actually will make sure that all the questions are answered, maybe later sending an email of some sort. Next slide. And in these webinars, there is simultaneous translation into Russian. So if you want the Russian channel, you can select the audio channel Russian in the lower function bar of the Zoom window. You can lower the volume of the original English audio to understand the Russian translation better. And we're most grateful to Yuri, who's our Russian translator, for pristine work. One of the good things of having Yuri. When I sent him my slides this morning, he said, you have a spelling mistake. You need to correct it. So it takes someone like Yuri to put us right. Next slide, please. And just to highlight to you that we have our next Congress, the 2026 ESC Congress, which is going to be under the title Breaking Barriers in Sexual and Reproductive Health, will be in Belgrade, Serbia, from the 6th to the 9th of May. The program is absolutely packed, and it will be great to see as many of you in Serbia in May of next year. I think this is the last slide, and I'm going now to give the microphone to Tamar, who is our colleague from the UNFPA, to do the official welcoming for this webinar.
Thank you very much, Dr. Kubba. Dear colleagues, dear participants, I'm honored to welcome you on behalf of UNFPA Regional Office for Eastern Europe and Central Asia to the webinar Climate Change, the Impact on Women's Health. UNFPA, the United Nations Population Fund, is a lead UN agency working in the area of sexual and reproductive health, supporting the countries to accelerate the progress in achieving universal access to sexual and reproductive health, in line with Sustainable Development Goals and the Program of Action endorsed at the International Conference on Population Development in Cairo in 1994. Since Cairo Conference, we achieved a lot, but the agenda is not accomplished yet. And we are honored to work with our partners, including ESC, to accelerate the progress in sexual and reproductive health in the region. Together, we are addressing the priorities of countries of Eastern Europe and Central Asia to eliminate the barriers in access to sexual and reproductive health and to respond to the emerging challenges. Of course, climate change is one of those. Climate change and sexual and reproductive health and rights are interconnected in many ways. For instance, the heat waves are linked to poor maternal and newborn health outcomes, including miscarriages, low birth weight, the complications of the pregnancy and delivery, and of course, rising temperatures increase the spread of vector-borne disease. In addition, it's linked with destruction of infrastructure during extreme weather events, and the access to essential health facilities are limited in such situation. And many health services, several packages on the sexual and reproductive health are interrupted, including maternal health services, family planning, screening, neonatal service, etc. Integrating sexual and reproductive health and rights into climate policies is crucial for building resilient health systems. The nationally determined contributions, NDCs, are climate action plans submitted every 5 years under the Paris Agreement, adopted under the United Nations Framework Convention on Climate Change in 2016. Referring to the previous round of NDCs, only 2 out of 12 countries of Eastern Europe and Central Asia have included sexual and reproductive health and rights in their national action plans, NDCs. This year, the countries are developing and submitting a new round of nationally determined contributions, NDCs, and the global conference will take place in Brazil in the end of the year. So UNFPA, together with its partners, academia, professional societies, government and private sector representatives, advocates to incorporate the sexual reproductive health in the national policies and plans to make sure that potential impact of climate change is addressed and the risks are mitigated. We support the studies, policy briefs, and policy papers to accelerate the evidence-informed policies development and implementation in the countries of Eastern Europe and Central Asia. I would like to take this opportunity to express our deep gratitude to ESC and the organizers of this webinar, which is tailored to the needs raised by countries of Eastern Europe and Central Asia. Our special thanks to Dr. Ali Kubba, Dr. Jane, Ria, Esther, and all ESC officers for their support. I believe this webinar will meet the needs of the countries in Eastern Europe and Central Asia and will be interesting for all participants beyond our region. Wishing you a successful event and look forward to meeting you at our future joint webinars. Thank you very much.
Okay, thank you very much, Tamar, and we are absolutely on time. I just forgot to mention that we will have the recording of the webinar. We have 500 people registered for this webinar, and we probably will get about 200, 250 today. But the recording will be available for 6 months on the ESC website and on the UNFPA website, including the Russian translation. So without further ado, I'd like to kickstart this meeting by saying how lucky we are to have Professor Jane Hirst as our first speaker. Jane is chair of Global Women's Health at the School of Public Health, Imperial College in London. She's also director of Women's Health at the George Institute for Global Health, and she's a visiting professor at the Nuffield Department of Women's and Reproductive Health at the University of Oxford. So you can't actually have a more informed expert on this issue to address the topic of women's health in a changing climate. The floor is yours, Jane.
Thanks, Ali. And just confirming, Ali, you can see the slides correctly?
I can, definitely.
Good, good. So it's a huge honor to be here today, and hello to all the participants joining online or who might be listening in at a later date. And thank you to Tamar and the UNFPA team and ESC for hosting this important event. As Ali said, what I'm going to be talking about today is women's health within a changing climate. And as Tamar has alluded to, this issue of extreme heat and the world getting hotter is something that is now at the top of the international agenda. This is from back in 2023 when Secretary General Antonio Guterres, famously said the era of global warming has ended, the era of global boiling has arrived. And accompanying this statement, he released his United Nations Secretary General's call to action on extreme heat, which included a lot of actions for member states to take, both at the country level in terms of mitigation, so reducing the amount of fossil fuels we're burning, but also adaptation. And I think it's agreed that we need to be focusing on both. This is, a very real problem around the world. This is a little clip from the Times of India, which is from last week, showing, scalded Delhi hits 54.4 degrees on heat index. So the heat index takes into account not just temperature, but humidity. And I think we can all agree that, that is far beyond, our comfort zone as human beings. And we know that this is becoming more common. Around the world, this data has been shown, several times, but when we see the trends around, the global air temperature, we can see for, since about 1980, but certainly more steeply since 2020, that curve is really on a very steep upward trajectory, with no signs of flattening out or coming down. I saw in the paper yesterday here in the UK, in The Guardian, new data coming out about dramatic rises in intensity of weather events. And I'm sure we can all, relate to this in our own countries. More severe storms, droughts, cyclones and hurricanes in areas that are prone to those regions. And of course, flooding, which is a major problem in many countries around the world. So I guess the question, though, is what does this all have to do with health? And, the Lancet have been putting out their countdown reports for the last few years, really sort of summarizing what we know about the effects of climate change on human health. And in terms of climate change, the most notable change is the rise of extreme heat events. That is certainly the thing that accounts for the most deaths, but of course it covers many other areas, flowing on for that drought and food insecurity, etc. But I guess that the highlight, notes here that many of you will be familiar with, that our annual mean surface temperature in 2024 was 1.5 degrees above pre-industrial levels. 61% of global land has seen an increase in these extreme weather events, and heat-related mortality, particularly in older people in society, has increased by a huge 167% when compared to 1990 levels. And millions around the world affected by food insecurity. But today we're here to talk about these effects on women, and it's often said that the effects of climate change are not on health, are not gender neutral. And I think Tamar alluded to a few of these areas which there can be direct effects, and there can also be indirect effects on health. So today I'm going to focus, as I'm an obstetrician, around effects on pregnancy and reproductive health. But we also know there are gender differences in the effects of mental health, of heat wave conditions, notably actually that for heat waves, men are sadly more likely to die from suicide than women during those events, but women are more likely to suffer anxiety. And we also know amongst older women that they are more likely to die from heat stroke, probably due to the fact that women live longer and are living with more comorbidities, cardiovascular, particular in their later years. But we can see that there are a number of indirect effects, which I'm not going to discuss so much today, but are probably on a population and cost level, what are really going to make a huge difference in our ability to all move forward in terms of development in the next few years. So this talk I'm going to discuss today, I have divided it around, thinking firstly about understanding the risks in pregnancy. And I'm going to now tell you a little bit about, epidemiological and physiological evidence for what we know about heat in pregnancy. And then I'm going to talk in the second last few slides about, so what can we do about it, which is really, I guess, where most of us really want to know, what do we do about this? So what do we know about the effects of heat on adverse pregnancy outcomes? Well, thankfully for me, the group led by Matthew Chirsich in South Africa and colleagues at the end of last year published a very extensive systematic review, reviewing all the publications up until the end of last year, which is almost 200 publications looking at this association. So we've looked at it a lot. And what we know is that risks of preterm birth are generally increased. Risk of stillbirths are increased across most studies, although you can see there the confidence interval for the odds ratio crosses 1. So there are some studies where that increase has not been shown. Interestingly, the risk of gestational diabetes is also increased, and risk of congenital abnormalities is increased, as are hypertensive disorders, and if we look at any obstetric complications. And if you look at that graph on the left, what you can see is all the different outcomes that have been looked at, and clearly most of the studies have looked at preterm birth and low birth weight, with fewer studies looking at some other complications which are also of importance. But crucially, I think, is where does this evidence come from? And most of it, you can see through the darker colouring here, comes from North America, China, a little bit from Australasia, single studies mostly from across Africa and some countries in Asia. Not a huge amount from the region where we're talking today about the sort of Eastern European region, but some, occasional studies. But I think, we still need a lot more evidence looking at different climate exposures across the world. So what happens in pregnancy when women are exposed to excess heat from their environment? And why do we think, could women be at risk of heat during pregnancy? Well, the good news is for us women, and pregnant women in particular, is that nature has built in a few things to protect women against heat, given that we know that during pregnancy there is increased heat gain from the baby itself, fetal heat production, an increase in basal metabolic rate, and a reduced surface area to volume ratio, so you can less effectively shed heat. So what nature has built in is it lowers maternal core body temperature, it lowers the threshold at which sweating is initiated, and it increases the ability of the tissues to absorb heat, so what we call specific heat capacity. And, an increase in the plasma volume and skin blood flow helps dissipate some heat also. So actually the heat chamber studies would suggest that pregnant women aren't uniquely susceptible to heat stroke. In fact, they're pretty much the same as non-pregnant controls. But what's different, of course, about pregnancy is that we have a fetus on board, and that fetus can be affected by, extreme, changes in temperature. And how is this affected? Well, this is still work in progress. And my group and a number of groups around the world are really trying to work out what are the mechanistic pathways and biological pathways leading to these adverse pregnancy outcomes. So a number of theories around hemodynamic changes to the blood flow to the placenta and the baby, maybe changes in cytokine production, heat shock proteins, differentiation in oxytocin, inappropriate oxytocin release. There are a number of different theories, but at the moment they are just still all theories. The WHO last year put out a draft conceptual framework about how they see these things acting both directly and indirectly and leading to all these adverse events. But I think, this is very much still being worked out as to what are the key biological pathways by which these things are working. So what I'd like to talk about now is pivot a little bit to some of the work that we're doing in India, where, as you could see from that earlier slide, they do suffer from very extreme temperatures. So it makes it a good place to study this, and they're very concerned about the effects of heat on their population. And the work which we're doing now really started from work led by Dr. Rekha, who's circled here in this picture of a group of investigators from Sri Ramachandra, and you can see me in the front row there, where Rekha did her PhD study looking at the effects of occupational heat exposure on a cohort of 800 pregnant women from a state in India called Tamil Nadu. Now, she recruited these women, so she recruited half of them who were working in heat exposed occupations, like out in the fields, maybe in a brick kiln factory or a bakery or somewhere where they were exposed to heat. And half of the women roughly matched on social demographic characteristics, but working in less heat exposed environments, like say in a school classroom or a indoor working environment, maybe in a factory that wasn't generating too much heat. The women were recruited early in pregnancy, and she studied some outcomes listed there. How is heat exposed defined? Well, this is a really good question, because for pregnant women, we don't actually know what the safe threshold for working heat exposure would be. We've used the threshold limit value from the sort of occupational hygienist definition, and this is actually based on work done in male army recruits back in America back in sort of the 60s and 70s. So how relevant it is for pregnant women in India is debatable. But this is talking about what we call wet bulb globe temperature, above 27.5 degrees for heavy work and above 28 degrees for moderate work. So wet bulb takes into account humidity, temperature, airspeed, and solar radiation as well. I won't go through the whole study, but just to say it was quite a complicated study with measurements across each trimester of both the area heat stress, so trying to measure what was the temperature and humidity, physiological measures, and perceptions of heat. And we can see here just a graph to show that, her cohort was roughly split into those who were on average quite exposed and those who were non-exposed. So quite a nice separation of those peaks on that graph. And the groups were broadly similar on social demographic characteristics. So cutting to the chase, what did this study show? Well, quite concerningly, what it showed was a really marked increase in the odds ratio of having any one of these adverse pregnancy outcomes. You can see here your miscarriage, low birth weight, preterm birth, stillbirth, rising up to 17.2% of the heat exposed group compared to 9% of the unexposed group. And if we took miscarriage alone, that was an odds ratio, 3 times as many. So in this particular population that this study was done in, what this was meaning was for every 100 pregnancies, an additional 8 babies died, were born too small, or born too soon. And I think for all of us working in sexual and reproductive health, this is pretty concerning, because these are all outcomes that we're very concerned. We were making very good progress in reducing, but is it possible that climate change could set us on the wrong course? And this work has been, highlighted by the BBC, and I'm pleased to see that it's getting some recognition through forums like this and other international fora. But what this has led us on to is our current project, which we're doing, which is funded by the Wellcome Trust, called Heat in Pregnancy India. So leading on from the work that Dr. Rekha has done, we're trying to answer 4 main questions. And I think these 4 questions are relevant not just for India, but for every country. Firstly, who is most vulnerable to the adverse effects of heat in pregnancy? Clearly, around the world, literally, tens of millions of women will be experiencing their pregnancies through very high temperatures and through the summer months. And that may be in Europe, or it may be in Asia, Africa. And most babies are fine, but some are not. Who is most vulnerable? So answering that question is important. Secondly, do we know that babies are actually stressed by outside temperature conditions? And the way we're going to be looking at this is quite novel, in that we are partnering with a startup in India who've developed a low-cost CTG machine, so cardiotocograph machine, where we have fetal heart rate tracings from all across India. You can see in the little picture there all the little blue dots and red dots. And what we know is they're time-stamped and geolocated stamped, and we can match them with satellite weather data at that time. So can we see changes in the fetal heart rate during these extreme heat events? So when it is 50 degrees outside, do the baby's heart rates become more? Can we see this strain coming in through that way? The third question, sorry, is to really think in detail what is happening through pregnancy and the lactation period here. So we're going to be following a cohort of women through in India, in detail, measuring ultrasound measures, hemodynamic measures of the mum, biomarkers in the blood, and importantly, lactation studies as well, looking at the composition of milk and the timing of milk transition from colostrum to mature milk. And then probably, as I say, the big question that the policymakers want to know, as do, I guess, practitioners, is a bit so what, and what can be done to protect women. So we're hosting community engagement events, listening events with women and their families, as well as talking with policymakers to try and find those solutions that are practical. And so that the study itself is a big one. We're looking, as I say, using retrospective data, and we're also doing prospective studies, as I outlined, looking at individual heat stress and heat strain, maternal hemodynamic changes, changes in the fetus, uterus, placenta, leading to which we think are going to show signs of leading to reduced fetal growth, hypoxia, inflammation, and preeclampsia, which are leading to our poor outcomes at birth, and potentially poor outcomes, during early infant feeding. It's important when you're doing this work to realize that when you're looking at environmental exposures, there could be a lot of other mediating pathways and things that are changing as well with the seasons. So food, air pollution, acclimatization. So we'll be capturing data on all these things. And as I said, finally looking to see how can we adapt to this new reality. So that's our work that we're doing in India. The second part of my talk, for the final sort of few minutes here, is I'd like to talk a bit about, well, what can we do about it? What do we know about how we can protect pregnant women from heat? How can we protect vulnerable women who may or may not be pregnant, but what is vulnerability and how can we reach everyone? And then importantly, sort of moving beyond women, how has gender been considered in sort of adaptation interventions at the moment? Is it considered, and what do we know from that? So 3 different populations there of interest. So firstly, because I'm an academic, I have to, share with you all, a framework for how we're thinking about solutions for this problem. And there's, a number of sort of, not too dissimilar frameworks outside pregnancy. So we could apply this to, women who are maybe seeking care for other health services, or men or children. But essentially what we sort of should be thinking about is around, 4 different areas which we can act. The first is behavior change, and this is probably the most obvious thing. So, if there's a heat wave, people need to know how to keep themselves cool, how to, keep themselves out of the heat, not to go out in the middle of the day when the heat is hottest, to stay well hydrated. So this is often, sort of characterized under sort of hydration, shade, rest sort of recommendations for people to do. But this puts a lot of onus on the individual themselves to be able to make those changes. And they may, some women may not have the agency or ability or education to be able to do that. So it needs to be couched in other ways of thinking. The second area, which I think is something we often think about, is changes to our built environment. So the thing that everyone first jumps to is air conditioning, which of course is very helpful, in cooling buildings. But we have to think about, what about people who, for financial reasons, logistic reasons, or whatever, are just not going to have access to air conditioning. And I can tell you, working in the UK in the National Health Service here, our maternity building does not have air conditioning, and I'm sure that's not a unique thing in the UK. So when it gets hot, like today, the buildings can overheat. But we'd also need to think about building design. So there was a very famous study that was done in Ahmedabad in India a few years ago now, where they realized when they moved the neonatal unit from the top floor to the ground floor, suddenly less babies were dying. And that was directly because heat rises in a building. We all know that. But just that simple, or maybe not so simple to achieve logistically, but conceptually simple thing of placing your most vulnerable patients, like newborn babies, in the coolest part of your building, really can make a difference. And there are, of course, other adaptations like cool roofing technologies, better ventilation, green spaces around clinics, which can be very, very helpful in this regard. And then the third area that we need to think about is around health system adaptations. And what do I mean by health system adaptations? Well, part of this may be things like early warning systems, that many countries will have a heat health early warning system, but most countries don't target that message towards specific vulnerable groups. And where they do, mostly pregnant women and lactating women are not considered part of those vulnerable groups. So can we, reorientate those messaging to really reach our population of interest? The other things that we can think about health systems is, during extreme events, can we, move to more remote consultations where is appropriate? Can we change the timing of our clinic? Can we make sure that women, during extreme events such as storms and floods, still can have access to our health systems, through maybe digital or decentralized means, but really thinking about it from a systems point of view. And like most areas, when we think about changing things in healthcare, this all must be underpinned by solid policy, governance, structural, and in this particular area, climate financing interventions. So, who's going to pay for all this? Where does that come from? And can we, as a community in sexual reproductive health, can we advocate for our patients and make sure that some of this money is directed towards these vulnerable groups? So as examples of things that are targeted at pregnant women, the High Horizons EU group, which is co-led by Matthew Chersic and Stanley Luchters, from a group across Africa, have put out some examples of what this could look like. You can see here from these pictures, the difference between a hot clinic and a cold clinic, where, there's a difference in the roofing technology, solar panels for a water cooler, better ventilation, green space around the clinic. So these sort of things are important in how we can cool our spaces for our pregnant women and babies. And so I said then I'd talk a little bit about beyond pregnant women, if we're thinking about women in general, and particularly who might be most vulnerable in the society. Often those women who are most vulnerable are the ones who can't get themselves out of the heat because they are working as market sellers outside, or in India, there's a large number of people who work as waste pickers, street vendors, street sweepers, etc. Maybe people working as farm day laborers. These women are going to be particularly vulnerable because, if they don't work, they don't get paid, and their children don't eat, or they don't eat. So the Atlantic Council Climate Resilience Centre and the Self-Employed Women's Association, SEWA, set up this really quite innovative pilot study last year in India, looking at creating a micro insurance scheme for these women. So the idea would be during a heat event, the scheme would give them a digital payment of the equivalent of a day wage, which might not be very much, maybe €2 or €3 for some of these women, but it would mean that they didn't have to go out and earn that day wage. They could still feed their families. And so this is really now caught a lot of interest around the world, and is being scaled up by Wellcome and others. So it's really, really great news there. And then the final thing I wanted to discuss with you all is really about, what evidence do we have for adaptation interventions for health, and how has gender been considered within those adaptations for health? And kudos here to my really excellent MPH student from last year, Karthika Kumar, who led this work. So this is her findings, which I'm showing here. But the first thing to note is this map of the world here shows where actual studies have been done, looking to see how effective these community heat level adaptation interventions for health. This is not just pregnancy, not just women, this is all health. Where have they been done? And what is probably the most striking thing here is there are only 5 studies. Admittedly, she limited it to low middle income countries, but a similar review recently showing it across all countries found only a very small number of additional studies to this. Since she did her thesis, 1 additional study has come from Kenya. But I think the take-home message here is the evidence base for what we should do around protecting our populations from heat is very small at the moment. But it is something, it's not zero. And so these 5 studies which were identified mostly looked at using cool roofing technologies, you can see for the first 2, awareness program in the third, water rest shade programs in the last 2. So these are the sort of things that people have evaluated in research studies design. And I won't go through this whole table in the interest of time, but what we can see is there was a variety of sizes of these studies, designs of these studies, outcomes that these studies were looking at. So what this should be saying to you is we don't have an evidence base that we can do a Cochrane review on to say, if you did, an awareness program amongst all your women or all your population, you will improve this outcome. We don't know that yet, but hopefully the evidence will be coming. But coming back to the question that Karthika was interested in, and we were looking at, is how well has gender been considered even in this very small body of evidence we have so far? And I guess the bottom line here is, well, it kind of hasn't really been considered that much at all. So amongst the 5 studies, 1 study from India, the Vellan-Greeny study, scored quite well on the, I'm sure we've all seen this before, the gender unequal to gender blind, gender sensitive, gender specific, gender transformative scale. So it was very good. And the reason it was very good is it was co-designed with female community health workers. And so really sort of was trying to tailor to their specific needs and the needs of the different needs of men and women in their communities. The other studies, however, were pretty much gender blind across the board, with 1 scoring, just above that as gender sensitive. So what this tells us is that whilst if you are ever go to any of these big climate meetings like COP or even sessions at the World Health Assembly, there's a lot of high-level rhetoric about gender mainstreaming and things in this space. But actually, the evidence we have is that it's not possibly being implemented. Certainly in the research studies on the ground, there may be programmatic work, which is a little bit better than this. But I think it's something for us to take note of. So in conclusion, take-home messages for you all today. The world is getting hotter, and extreme heat is threatening gains in maternal and newborn health that we have worked so hard for over the last few decades to achieve. And I think this is really a moment when we can't look away from this challenge, even though things like, climate change and the US government are clearly looking in a slightly different direction. But, this is a real threat that is going to get worse. Pregnant women and their babies are a specific vulnerable population. And it's up to us as leaders in this field, I've said obstetrics, but also reproductive health, to get this message heard, by our governments and by our health systems, and also out to our women, of course, as well. And greater awareness and further research are needed if we are to understand how we can protect women, pregnant women and babies from these heat events. And, I think this sort of framework of targeting both behavior change, health systems, and the built environment and policy is definitely the way forward. So I'm going to stop there. So I'll stop sharing my slides, and very happy to answer any chats or questions which come up in the Q&A. Thanks, Sally. Over to you.
Okay. So thank you very much, Jane. Very clear, very impactful, and tells us that we need to really work harder and harder on developing strategies. And I think the message that we need to also take, which is your last closing slide, which is that we need to take these messages to our patients or the women we serve, to our colleagues, and to the policy makers. And we're looking forward to learning more about the heat and pregnancy study. So we're going to move into the second presentation, my presentation. And the title is Sustainable Services and Resilient Healthcare. I'm using the background of the Faculty of Sexual Reproductive Health, which is a faculty of the Royal College of Obstetrics and Gynecology in the UK. And as a matter of fact, in September, it will become a college in its own right, to be the College of Sexual and Reproductive Healthcare. I've left my email in case you want to specifically email me about this session. I'm going to have to ask Ria and Esther in the office to move the slides. So this is my declaration of interest. I have no conflict of interest in relation to this presentation. And the point we make, we people who do family planning and conception, is that the fact that family planning has actually prevented a lot of pregnancies in the past, technically 60, 70 years, means that the planet as it is now has fewer people than it could have had, and therefore fewer mouths to feed, fewer people who are causing pollution, and so on and so forth. And we have to get the message right to our users. Can I have the next slide? So the agenda is, I'm going to, there may be some repetition, but talk about where we are with climate change, the impact on women's health, and what we can do, because all of us are aware and anxious about climate change. But when we asked, and we did that at the last Congress of the Congresses that we've held, when we asked the medical and health audience about what they can do, there was much, much, much less capability of saying, this is what I'll do. So we have the 4 Ps. Personal, what I do myself to, in a way, help mitigate the impact of climate change. Professional action, what I tell my patients, the women I serve, and my colleagues. Pathway-specific activities, which is how I run and contribute to running the healthcare service in a region or a hospital or a place. and how do I influence the policy makers, the policy level activities. And you can see these slides. I'm not going to indulge with the images. If we have the next slide. So as Jane, with the UN General Secretary quote, the climate crisis is not coming, it's already here. As a matter of fact, it's been here for a while, so this is the time to act. The International Federation of Gynecology and Obstetrics, FIGO, talks about the 3 C's, the 3 top challenges in women's healthcare. And the top one is climate, the fact that floods, fires, tornadoes, heat waves cause disruption of food supply, of safe water, of sanitation, of transport, increase poverty, and cause displacement and therefore overcrowding. And of course, there is also the issue around pollution, and pollution affects health, but pollution, in addition to, for instance, extreme heat, kills much more people than pollution on its own. The second C is conflict. It essentially produces the same environment as climate crises like floods, tornadoes, and so on. There's loss of life, gender violence, disruption, as we've mentioned it, and mental health problems. And COVID is a surrogate for the next pandemic. We know what had happened when we had COVID. We had restricted services. Women and men and families could not access some of the services that they needed to access. There is isolation, and again, many of the above issues. Next slide. And I thought, just to highlight a slightly different perspective of the planet heating up. We know that heat waves actually have caused 153,000 deaths a year. And there are 2 maps here. The top one looks at the number of heat wave days. And you can see, as a matter of fact, that Europe and Eastern Europe and Central Asia are one of the quite hot and heating up regions. And it looks in the second section of the slide about the percentage of change per decade. And there is still, again, you see more orange and more red in our region, but there is also an issue in Africa. Next slide. One of the things that has been highlighted in a group that I work with on climate change is the change in the jet stream. There is progressive migration of the jet stream northward, and this is anticipated, within many of your lifetime. I probably won't be around by 2060, but it tends to cause droughts in Spain. If you press again this slide, there is another item which will come. Okay, and so what will happen is in Europe, there'll be droughts in the southern part of Europe, and we have an altered storm pattern, heavier rain in Northern Europe. And a lot of you will remember the Paris Olympics, where we were anticipating fantastic weather in Paris, but we had these thunderstorms and severe rain. Next slide, please. So, we are facing a number of challenges. And the impact of climate change on communities is fairly clear. Climate change, this is not only heat exposure. Climate change causes an extra 250,000 deaths annually. It leads to the emergence of new diseases and exotic infection, vector-borne diseases such as dengue fever, malaria, and skin and soft tissue infections. If we have poor health infrastructures, that makes communities more vulnerable to the disruption of health systems, of food systems, causes malnutrition. Diarrheal disease will impact more on that, and heat stress. Displacement carries multiple risks as well. Mental health, loss of earning, and poor access to healthcare. And I've got sort of 4 images there. So if we go from right to left, the first image is the image of someone housed after a flood, and you can see the loss of, in a way, locality and the loss of resources, and that has to be, and if you look carefully at the individuals standing there, causes depression and mental illness. The next one, going right to left, is Dubai last year when there was a flooding episode. And of course, Dubai as a modern city, which has some capacities to deal with crises, not much happened. Some flights were affected from the airport. But next to it, at the same time, there was a flooding episode in Brazil, and about 50 people died. And the last slide shows some of the impact of these events, whether they are floods or droughts. This is a flood situation where a man is herding his animals to go to a higher ground. And what would happen? They'll have a smaller space to be in. Humans will be in close contact with animals, which essentially, I guess, allows the spread of disease and feeling vulnerable. Next slide, please. So climate affects the whole of the life course. I'm just going to sort of deal with the rather dark image at the top of the slide. This is from my own country. I come from Iraq. And this actually shows a solo fisherman actually fishing around midnight. Now, it could be because it's romantic, but as a matter of fact, adaptation to heat exposure may force people to change the way they work. But looking at the whole life course, so we know that, for instance, pollution, microplastics, which are in cosmetics and pharmaceuticals and food preservatives, cause infertility, can lead to pregnancy loss and implantation problems, chromosomal abnormalities, preeclampsia, and preterm labor. Extreme heat, we've already looked at with Jane, and it is very important to consider the burden of menstruation. Every month, 180 billion women menstruate. And of course, menstruation exacerbates vulnerabilities. Sanitary protection may not be available, and if it's available, may be expensive, and therefore it is competing with someone being able to sort of feed the family and themselves. It may actually cause problems with infections, especially if, for instance, the protection that is used is not sanitary, and that I think is important. But it also has a number of other vulnerabilities. Menstruation leads to anemia, which means people have to have access to medication, dysmenorrhea, pain, and again, we may need to have medication. You also will lose days of work, which exacerbates poverty. So these are things that we need to keep in our minds. Let's have the next slide, please. And we have the endocrine disruptors. They are linked to polycystic ovarian syndrome, to fertility, both male and female, to early menopause, and to endometriosis. There is very good evidence that ovarian cancer is more common in areas where there is very high pollution. And of course, in the menopause, looking at the life course of the woman, heat, increasing intensity, increasing heat, increases the intensity and the duration of menopausal symptoms. And there's evidence that, again, air pollution would lead to bone loss. And there is now also evidence that eco-anxiety among young people is increasing and rising and causing not only anxiety, but actually causing to decisions about, life events, life courses, whether a couple would want to have children with this situation, with the climate. Next slide. And therefore, what can we do? What can we do personally? We have to think about reducing our own carbon footprint and encouraging others to do so. So green travel, cycling, green energy, not using fossil fuels. We're talking here about new homes being built with sort of panels that will essentially provide electricity to the home. You can buy less, eat less, consume less, and therefore cause less pollution and be healthier. I'm going to show a slide later about plant-based diet, because I think that is really one way that we can influence both the climate change situation, but also the health of the population. Food production accounts for 34% of global greenhouse gases and 73% of deforestation. This is really to sort of provide meat for us to eat, while a plant-based diet replacing red meat saves money, protects people against cancer, against dementia, against infections, and against cardio, renal, and metabolic conditions. Next slide, please. What about professional and pathway actions? Our colleagues, our patients, and the healthcare system. We need to empower our patients to think about climate, and sometimes my patients say, can't I come and see you in 3 months' time for my checkup? And I would say, actually, you would probably be better off to have a telephone consultation. Ensure that the SRH integration in national climate policy is done. You know, we are sexual reproductive health leaders. We need to look at our national climate policies and see how we contribute to them. And that is really essential. It is also essential that professional societies and academic bodies participate in the debate, providing evidence and influencing food practices, which we've already mentioned. We need to identify vulnerable patients and plan their management. So if we have someone with comorbidities, for instance, they may be looking at their fertility or attempting a pregnancy. We need to sit down with them and agree a plan, for instance, if there is disruption of healthcare services. Pharmacies are our backup in the community, and they can lead on a number of healthcare issues. So working with local pharmacies to ensure access to medicines, the supply of medicines, and making sure that patients know where to go for their medication. We also need to educate patients about managing side effects. In contraception, people stop contraception because they may be anxious about one side effect or another, and that will make them more vulnerable to mistimed and unplanned pregnancies. And it actually is a good investment in spending time to talk about side effects anticipated with whatever therapies or contraceptive methods we're giving, because that will allow the patient to cope with that when they may not have access to you as a healthcare provider or to information. And there is now wide use, and we have social media, of course, to, for instance, videos and recordings of webinars and that sort of thing to educate the population. Next slide, please. So what can we do? So cope by changing lifestyle. So working times to avoid intense heat, pace yourself, hydrate, and wear head coverings. Educate about managing contraceptive side effects, which we've talked about, and switch to plant-based diet, which I will talk about. Burden of menstrual morbidities is very high and causes rises in menstrual poverty. So we need to teach that heavy menstrual bleeding is not a normal state, and aim for amenorrhea by using either contraceptives that induce that or other methods. And we have to challenge myths. Amenorrhea is not an abnormal state, because if you think of 100 years ago, most women were either pregnant or breastfeeding, and there was quite a lot of amenorrhea. So amenorrhea through menstrual suppression is ideal for a lot of gynecological morbidities, such as heavy menstrual bleeding, endometriosis, premenstrual tension, abnormal bleeding, and ovarian cysts. We need to build resilient systems to avoid disruption of services when there are crises. So promoting, for instance, long-acting reversible contraceptives, which means if a woman has an IUD which works for 8 to 10 years, if there is lack of access to services, she remains contracepted. The same would also apply in what we call immediate postpartum contraception. We now are promoting this for women. So a woman delivers, and you can, as a matter of fact, while she is still on the ward, fit a subdermal implant, which will give her excellent contraception for the next 3 years. Or if you're doing a cesarean section, you can put an IUD, whether hormonal or copper IUD, before you close the uterus. We need to deregulate. We feel that many of the contraceptives are so safe, they could be provided over the counter, and that will make it much easier for women to access these methods. Online pharmacy provision is already very much the norm. So during the pandemic in this country, women who contacted sort of online services, they would essentially have a screening questionnaire through the website, and then will be directed to a source where they can have their medication. We now feel that we can provide, for instance, for oral contraceptives, a year supply, and we would campaign, and this is where you need to influence your policymakers, that contraception becomes free. We need to encourage self-management, for instance, giving contraceptive injections. We already have the obesity treatment methods, but we also have, for instance, Cyanopress, which is depomedroxyprogesterone acetate, but given subcutaneously, very easy to use and puts the woman in control. We also need to think about our other colleagues in the healthcare system and emphasize and accelerate the role of nursing through task sharing and task shifting. And as we said, the pharmacy has a very essential role. In many of the countries in Eastern Europe where I've been, there is this resistance to allow pharmacies to sort of take charge, definitely, of some of the women's health issues and some of the contraceptive issues. And one of the arguments that tends to arise is to say, well, if there is a vulnerable person going to the pharmacy, they may need safeguarding, we need to see them. As a matter of fact, you know, my registrar in the hospital where they see someone that they may think has been exploited, for instance, would need to direct them to a safeguarding center. And all we need to do, the answer to that anxiety, is to make sure that pharmacies are part of the safeguarding network. And that will solve the problem of this anxiety about patients going to pharmacies for their supplies. Next slide, please. We're nearly there. How do we make our practices sustainable? So we need to reduce our carbon footprint. So we said consume less, produce less waste, cycle to work, walk to work, and use friendly communications to make sure that your colleagues are comfortable with the environment they're living in. And I think that is important. There is already a lot of anxiety in the system. We can reduce the number of consultations. We don't necessarily need in-person follow-up. We can do it by phone. We can also reduce the number of tests that we do, and therefore the plastic that we use when we use needles to take bloods and that sort of thing. Using pre-visit videos to educate patients so that when they arrive in your clinic, you actually have less time with them. It allows you to see more people. And there are changes, obviously, improvements in science. So, for instance, the human papilloma vaccine, which we think is really, really, really important. 10, 15 years ago, we had 3 doses, then 2 doses, and now we can actually give just a single dose to teenage girls and boys as part of the vaccination. Self-testing, I think, is very important. We think that in the next 5 years in the UK, women can self-test for HPV, the HPV virus. And if you do self-testing, this is just sort of a comparison. So if a woman takes a vaginal swabs, puts that in an envelope and sends it to the lab, she spends 423 grams. If a woman actually comes to your clinic to have a cervical cytology test, she spends 3,670 grams. And you can see that the difference there is absolutely massive. And therefore, I think near-patient testing would be really good, giving results to patients more or less immediately. Reduce the use of plastic and shift to reusable instruments and PPE. Research done here, published in the BMJ, suggests that women, if you explain the reason for using the reusable instruments, they would actually support that. And of course, in a lot of situations, a non-touch technique means that you don't necessarily require, for instance, to use gloves if you're not, if you're taking sterile instruments into or products without touching them, and encouraging the use of biodegradable sanitary products. Next slide, please. We'll finish in a minute. I'm going to just go very quickly on this. This is what Novak Djokovic promotes. It's good for you. So it's good for the individual in that it has beneficial hormonal effects, reduces inflammation, reduces ischemic heart disease, and there's evidence that it actually reduces pancreatic cancer. It prevents a number of conditions, including prostate cancer, and introducing plant-based food in hospitals reduces the cost to the hospital, to the to healthcare system. It reduces food wastage. It reduces foodborne diseases, which are associated with raw meat or eggs or things like listeria. In our hospital where I work at Guy's and St. Thomas's, we have, as a matter of fact, introduced a plant-based diet, and patients find it really good. Next slide, please. We'll shift to the next slide, I think. I was going to talk about pollution. So next slide. And this is my closing slide. So we need to continue the conversation among our colleagues, conversation with our patients, and with our policy makers. I think we can make a difference. You may think, well, plant-based food, what difference would it make? It makes massive difference. You know, self-testing at home makes a massive difference. And we have to say that what is good for women in normal times is good for women anytime. Reducing visits to hospitals actually helps women to continue to sort of work if she does shift work, for instance, and all the interventions, for instance, menstrual interventions to achieve amenorrhea would be really helpful. And remember that the time to act is now. So we need to educate, we need to lobby, we need to keep records and in a way influence our policymakers and build partnerships. The rainbow slide here is from the faculty, and it actually looks at a life course approach to all the interventions that women will find useful. I'm going to stop there. I think we are going about 2 minutes over time, so we have at least 15 minutes for questions, and I'm going to so we have Jane. Let's see where the Q&A section is. There we go. We've got, it says here that we have 5 questions. So I'll read the question and then we'll see who answers. So it says, hello from Italy. So that is okay. Another greetings slide. It says, are there any examples or experiences of implementing mitigation measures into health systems to learn from? I think Jane did show a number of things as far as heat exposure is concerned, and I have, in a way, discussed with you the introduction, for instance, of plant-based foods in a hospital. We definitely can, in a pathway of healthcare environment, can work to reduce visits to help self-management. I can tell you that in the hospital where I work, which is a huge obstetrics and gynecology unit, one of the biggest units in the country, 1/3 of our follow-up consultations are by telephone. And you don't need to be in the hospital to do your telephone consultations, because modern technology with electronic patient records allows you to have access to a patient's records. So these are things that I feel in my immediate environment we can do. But Jane, what other suggestions do you think we can make? Good.
Thanks, Ali, and your great question. And so just to be clear, so mitigation is sort of reducing carbon emissions that we have in our health system, and adaptation is protecting women from the effects of climate or heat or whatever. So when we look at mitigation activities, there's actually quite a few things that have been used successfully. And I think in the UK, the RCOG had a green maternity challenge last year, which was actually very, very successful. And these were sort of locally implemented projects, so things that we could all maybe take back to our own units. And a couple of of the finalists that stood out to me, one was a midwife sonographer who was working in one of the remote Scottish islands, which is right at the tip of the UK. And what she was finding is that she was a sonographer midwife, but she'd never been trained to scan, babies' hips for congenital dysplasia of the hips once the baby had been born. And so all the parents who delivered on that island, if their baby had clicky hips, they had to fly, several hours to Aberdeen or wherever the centre was, the referral centre, to have an ultrasound, which more than likely was going to be normal, and then they flew back. And so the carbon footprint and cost of sending those families down to the health system was quite substantial. So actually, by convincing her local health authority to send her on a training course so she could learn how to do this locally, and then making sure they had the right probes and ultrasound equipment in the hospital, making sure there was a sustainability plan beyond her if she, went away. It actually was quite a nice example of how they were able to save quite a lot of carbon miles, I guess, from those flights, and also far more convenient for the families involved. So that was a great project. The other area in, I know it's quite pregnancy focused, but the other area in pregnancy care, which is really a big carbon contributor, is nitrous oxide in our delivery rooms. And when they have looked at this, nitrous oxide is actually the worst thing that we do as obstetricians in terms of how we contribute to the carbon footprint. And the reason for this is that it's a very potent greenhouse gas. And that most of the nitrous oxide that certainly in the UK that comes in the canisters or whatever to the hospital, only about 5% of that actually goes into the patients. The rest of it is either wasted, in terms of it leaks out of like leaky pipes and leaky systems, or it's returned to the manufacturer when we think it's sort of running low, and the manufacturer just discharges it into the atmosphere. So there's a huge piece of work now around reducing carbon footprint from nitrous oxide. And I think in maternity services, we're one of the biggest users of that, certainly in the UK. So there are a couple of examples that, things which are working to reduce that carbon footprint. And I echo what Ali's saying, around other things, changing foods and things that are used in your units, thinking about things like where, are you using all disposable for everything, or could you be using some washable materials? Could you be sterilizing your speculums and things rather than having plastic ones? It all helps. So yeah, that would be my thought. But yeah, building on what you were saying, Ali, in your talk.
Yeah, so when you can have the recording and look at the list of things that we've suggested, Tamar has just, in a way, alerted me to the fact that actually every month only, it's not 180 billion, which is obviously a huge number. It's 108 million, I think, women that menstruate every month. So there is a typo, which I read but didn't really think about in a way. Okay, there are other questions, a couple more, I think. There's a question, I'm assuming from a midwife, so I'm going to read it. It says, great presentation, but please acknowledge that competent midwives, well integrated in the health system, can provide up to 90% of services that Dr. Kubba is sharing. Ensuring that women have access to midwives is the best investment and what women want. Importantly, how can we ensure midwives are already prepared and ready to provide SRM and AH services when crisis hit the community. So yes, when I talked about nurses, I should have actually said nurses and midwives, and I fully agree with you. But Jane, the question is, how do we ensure midwives are, as prepared and ready to really take the burden of care during crisis situations?
Yeah, no, firstly, 100% agree that midwives are, the backbone of our maternity services, and in countries where they don't have midwives, often it's obstetric nurses who are, or community health workers who are shouldering a lot of that burden. So yes, I'm with you there. I think, some of those areas that I was highlighting around, education of women and behavior change and things are really going to be fall on the responsibility of midwives and those who are dealing with the women long-term, day-to-day, to really make sure that people understand why the messaging is important, but also make sure that they're able to take changes where is needed. So I think midwives are crucial there. Midwives also are essential, in terms of, on the mitigation agenda, trying to lobby for more effective use of materials within the healthcare system, as I was just alluding to, getting rid of disposable things for reusable things, making sure that, I think Ali, you mentioned, no touch techniques for some things, we may not even need gloves. And essentially all the messaging here is not specific, I think, to one cadre of the health workforce. I think it's across all of us. And remembering, when I say, sorry, my slide did say, as obstetricians, we are leaders, but of course midwives are leaders as well in women's health and reproductive health around the world. So apology for my oversight in my slides, but I see you guys as co-partners in pushing this agenda forward.
Okay, and there was a comment about shifting from sort of meat to plant-based food, and there obviously is a challenge in relation to persuading people, but also cookery classes and where they shop for plant-based food. But in a way, the anxieties that people have about, for instance, can I have my protein or my iron from plant-based food are now resolved, in the sense that plant-based food gives you very good protein, probably healthier protein than you get from meat, as well as plants that have iron and other essential elements as far as the body is concerned. I mean, one of the things you notice, for instance, definitely in big metropolitan areas, is that there are now an increasing number of plant-based restaurants, which where people can sort of, at least taste the food and then move on. And it is definitely cheaper. It's definitely cheaper for women. There was a question about, I assume it's someone that wants to join the ESC, which is to give the email. So we will definitely do that. Ria will be typing it, I think, in the chat as we speak. And it is, I think, on the flyer for this webinar. And if you just Google the European Society of Contraception, so don't put ESC, because that will give you European Society of Cardiology, which is much bigger than our society, then you would be able to get into the system. I think we've made time, actually, because I see, let me see if there is any other question. There are a couple of greetings, so thank you very much for that. And it's therefore now gives me pleasure to ask Tamar to come back and do the closing remarks.
Thank you very much. Dear participants, I think all of you enjoyed excellent presentations made by our distinguished experts, professors, and I think we learned a lot. First of all, the solutions to be applied to the policy and services, but also some very good suggestions and simple issues which can transform the services with minimum, let's say, additional expenditures. Of course, in the countries, especially in the countries of Eastern Europe and Central Asia, heat exposure is a problem. Another problem is that we do not have comprehensive data on heat impact on maternal health, neonatal health. But the point is that every word, every information we receive today is applicable to our interventions, to our policies, to our programs before the problems arise. The issue is that we definitely need to be ready. We definitely should be prepared to reduce the risk for women, for children, for all vulnerable groups. And please do not forget the workforce, sexual reproductive health workshop, the workforce which are also affected by global warming. So I'd like to express our deep gratitude to our speakers, to participants, for interesting questions, for your attention, and many thanks to interpreter, Mr. Yuri. You made a fantastic job. And once more, I'd like to repeat that the recordings of both Russian and English versions of the webinar will be available for all participants and for those who were not able to join us today. Wishing you a nice evening, nice day, and look forward to meeting you soon. Thank you very much.
Okay, well, thank you very much, Tamar. So I was actually going to do my thanks, one to you for chairing and closing the session, to Yuri for the translation, and thank you to Ria and Esther, who have been backing up this meeting, especially progressing my slides, because my iPad can't do that. And great thanks to Jane for an absolutely splendid presentation. As we say, keep the conversation going. So you definitely would be hopefully with us when we do another series of webinars. We hope sometime later in the year, as our collaboration with UNFPA carries on. And we hope that some of you will be joining us in the Congress, which is around this time next year. So without further ado, and now that we are more or less on time, again, I wish you a very good evening or night, morning, and hope to see you very soon. Thank you very much.
Thank you.